The background for Atlas is that we used a drug called Axitinib, which is a VEGF receptor tyrosine kinase inhibitor that's widely used in renal cell cancer and some other cancers. It was not the first generation, but the second generation of these agents, and so it was a cleaner drug with potentially less side effects and therefore more tolerable. And there had been other studies done in the adjuvant setting with sorafenib and sunitinib and then subsequently pazopanib that have since been reported. So the premise with the Atlas trial was to use Axitinib, a drug approved for metastatic renal cell, in the adjuvant setting for up to 3 years to try and improve the disease-free survival in patients compared to the standard. In the Atlas trial, we accrued more than 700 patients. We randomized 1-to-1 to Axitinib or placebo, and the study, by its premise, enrolled patients that were higher risk than normal to relapse. Most of the patients going on were PT3 or had nodal involvement at surgery with no residual disease. There was a small selection of patients who went on early in the study, about 11% who had T2 disease. So what we saw in the study was that at the interim analysis, there was no significant difference between the arms per the independent radiological review, and that led to a closure of the study. And those data were presented here by Marine Gross-Gruppel on behalf of the Atlas investigators. Interestingly, what we saw when we did other analyses were the investigators at the sites were somewhat more optimistic about the difference between Axitinib and the placebo, even though they were blinded, and so the curves were further apart. And then when we did other analyses, what we found was that the higher risk patients, and in fact the highest risk patients, had a separation of the curves that was more significant. So what we found was that in actual fact there was a potential benefit to giving these sorts of agents to patients that have the highest risk localized or locally advanced renal cell, and really no advantage in the lowest risk where there's totally no difference between the two curves. From that perspective, this follows up on things that we've seen in other studies where there is a relationship between the localized stage and therefore the risk, the higher the stage, the higher the risk, and potential benefit from VEGF TKIs, which we saw in the STRAC study with sunitinib that led to the approval of that drug as a year's adjuvant therapy in the United States by the FDA. We're also in the study called the PROTECT study, which incorporated pazopanib versus placebo. There were very distinct indications that dose intensity with the higher dose could produce an advantage, and even though that didn't impact the primary endpoint, there are very distinct data from that trial that show that drug exposure and the starting dose correlate with a potential advantage to giving these agents. So overall, I think that the Atlas study contributes to our knowledge in this area, in that it appears that the highest risk patients may be candidates to get these drugs. In this case, the approved drug in the US is sunitinib, but I think also we're going to do further exploratory work looking at the dosing of Axitinib in the Atlas study to see whether the dose intensity correlates with a better outcome. This is quite complex because Axitinib, when we use it in the metastatic setting, we can not only de-escalate the drug dose for side effects if we need to, and also pause treatment, which is a standard across all of the VEGF TKIs, but also there's room for dose escalation from the initial dose of 10 milligrams a day up to 20 a day. So our analysis of that exposure is complex and requires us to go through almost patient by patient to do it. It's a little different to the other studies, but we aim to present those data at a future meeting.